So thank you everybody for coming out today. I'm Samir. I've met, I think, everybody here at some point. I'm one of the C3s in the program, and today I'll be talking about simple congenital lesions, and specifically the story about the ASDs, VSDs, the holes in the heart. But even for that, not everything that can be covered about this topic, because it's very difficult to do that all justice within an hour. But we'll cover what we can with a focus on the echo findings. I do not have any disclosures, conflicts of interest, and the objectives for this presentation include basic understanding of the embryologic development of the interatrial septum, understanding the anatomic classification of ASDs and VSDs, distinguishing between different ASDs and VSDs using echo, and recognizing complications and lesions that are associated with ASDs and VSDs. I'll go over kind of the background, embryologic development, echo findings, and associated features of PFOs, ASDs, and VSDs. And so just a brief note about embryology. This kind of shows in a very short summary how the atrial septum develops. They begin with this heart tube that's not really structured yet. You'd get the septum primum forming caudally from the superior portion of the what starts off as a common atrium and moving towards the endocardial cushion, which is just this little button in the middle of the heart. As the septum primum starts to form, the hole that is closing is called the ostium primum, which is where the Primum ASD name comes from. And then eventually the septum primum will fuse with the endocardial cushions in the middle of the heart. After this happens, a second orifice forms within the septum primum, and that's called the septum, the secundum, or the ostium secundum, and that's where the Secundum ASD name comes from. And then after that's formed, you get the septum secundum forming on the right atrial side of that. And then this comes down, but it leaves an opening between the or a hole remains within the septum secundum, and that's where you get the foramen ovale. During embryologic development, foramen ovale is important to allow shunting of oxygenated blood from the right side of the heart, which is oxygenated by placental circulation. It allows shunting of that over to the left side of the heart. And then shortly after birth, it's supposed to close off, but it remains open in a fairly large number of people. So to begin with, we can talk about the foramen ovale. So the foramen ovale, or patent foramen ovale, is a common finding. Autopsy studies have reported that up to 30% of adults could have a PFO. Most people with PFOs are entirely asymptomatic, and notably PFOs are not ASDs because no septal tissue is actually missing from the atrial septum, but rather there's an incomplete fusion of those two layers, the septum primum and the septum secundum, after birth. So again, the foramen ovale is a hole within the septum secundum, and it's important in fetal life to allow this shunting of blood from the right side to the left side, which in utero is oxygenated blood coming from the right. So here's some pictures of a patient with a PFO. So the first picture on the left is an apical four-chamber on transthoracic. Pretty unremarkable picture overall, and notably, if you focus on the right side of chambers, they are normal sized, which will be compared to some pictures we see later on. And then on the right, there's a bubble study done. And so you see, sorry, it's a little choppy. So you see early transition of bubbles over to the right side of the heart, and a grade 2 pattern after about 3 beats. It's hard to appreciate on this picture because it's a little bit choppy, but the intraatrial septum can also be seen, and it's quite mobile, which we'll better appreciate on the next picture. So this is a transesophageal echo of the same patient at the mid-esophageal level, at the short axis at the level of the aortic valve. And so here you can see that there's a highly mobile interatrial septum between the left atrium and the right atrium. And on bubble study, you can see the same transition of bubbles moving over to the left side of the heart. And again, a little bit hard to appreciate just because of the choppiness, but you can see that it doesn't pass over with every single heartbeat, but rather there's some variation, which is due to respiratory variation. And so this is very consistent with patent foramen ovale. So PFOs often are not associated with any other cardiac abnormalities, but they can be associated with this finding of an interatrial septal aneurysm. And then they can also be associated with some other systemic features such as paradoxical embolism and stroke. However, most people who have a stroke and a PFO, the two are not necessarily related, but in a subset of people that could be secondary to that PFO. So atrial septal defects, which are not inclusive of PFOs, include three main types, but one fourth type is sometimes grouped in with them. So the four types are Secundum ASDs, which are labeled on this diagram here, Primum ASDs, inferior and superior sinus venosus ASDs, and coronary sinus defects, which are technically not an ASD, but they are a type of interatrial communication, but they don't involve the atrial septum. So Secundum ASDs are the most common type of ASD. They comprise about 60 to 75% of all ASDs, and they are a deficiency of the central thin portion of the atrial septum. They can have quite a varied shape. Sometimes they're circular, oblong, elliptical, and it's generally considered the only type of ASD that can be closed percutaneously. However, that's also an evolving field, and there are there's some strategies to potentially close other types of ASDs as well in the works. Echo is a very important modality in understanding the anatomy of ASDs and how they should be managed. They're important to understand if there are any other associated lesions that may require surgical management, such as partial anomalous pulmonary venous connections or significant TR. And it's also important to assess the amount of septal tissue around the ASD and to determine if there is a large enough rim for a percutaneous closure device. And so usually we look for at least a 5 millimeter rim around each aspect of the ASD. So coming back to our diagram, Secundum ASDs are essentially a residual flow between the septum secundum and the septum primum, either caused by excessive absorption of the septum primum or insufficient growth of the septum secundum over top of the hole. And it's the only ASD that actually occurs within this fossa ovalis. So on the left, we can see another apical forechamber of a patient who has an ASD. One difference compared to the previous picture is that the right-sided chambers are significantly enlarged. So you can see some RV enlargement and right atrial enlargement. Secundum ASDs are best seen on subcostal views, but you can also appreciate some of the secondary findings in apical forechamber. And then on the right, we do a bubble study, and again, we see early opacification of the right heart in about 3 cardiac cycles. And we saw these bubbles at rest and with Valsalva. And these findings, in conjunction with the right heart enlargement, strongly suggest an ASD rather than a PFO. And aside from secundum ASDs being the most common type of ASD, the position of this ASD sort of midway through the interatrial septum also partially suggests a secundum ASD compared to the other types, which I'll show you pictures of later. And in these still pictures, so the first one, panel A, shows a transthoracic subcostal view, where because the ultrasound beam is perpendicular to the interatrial septum, you get a better image of the septum and flow through it, compared to the forechamber, where you tend to get septal dropout artifact because the septum is also much further from the probe. And you can see color flow moving, or this orange-red color flow, indicating that there's flow moving from the left atrium to the right atrium towards the probe. And then in panel B, this is a transesophageal image showing, again, that interatrial septum with a clear defect. And then subsequently, you see flow moving from the left atrium to the right atrium. And then a 3D view on transesophageal echo showing the defect. It shows a circular secundum ASD with a large rim around the circumference. Compared with this picture in a different patient, which shows how the secundum ASDs can have quite a diverse morphology, with this one being much more slit-like. And you can also imagine how, depending on which way you view this in a 2D axis, it could have a vastly different appearance in terms of how big it is. The red arrow on the 3D image also points out the second, smaller Secundum ASD, which is not as well appreciated in some 2D plans. So Secundum ASDs are often associated with right heart, right atrial, right ventricular enlargement. They can also be associated with tricuspid regurgitation as a consequence of annular dilatation. And sometimes it can be associated with mitral valve prolapse, possibly from some altered left ventricular geometry from the RV overload. And Secundum ASDs are often isolated cardiac lesions, but they can be seen in association with other defects such as partial anomalous pulmonary venous connections, and they may be contiguous with other types of ASDs such as Primum defects or sinus venosus defects. So see if there's anybody who wants to take a vote, but this is a transthoracic echo, apical four-chamber showing a bubble study with early transition, clearly lots of bubbles. Anybody have a guess? Think about what kind of hole you think this is? ASD, PFO, VSD, holy moly, I don't know. Holy moly, holy moly. One vote. ASD, a lot of people saying ASD, yeah. This was the transesophageal echo for the same patient. Looking at the interatrial septum, you can see that there's a highly mobile septum with a large PFO and Doppler flow going through the tunnel that just hasn't loaded yet. And so I put this here to kind of highlight the diversity in PFOs, how they can be quite small, but they can also, like in that first video I showed where there's just a small number of bubbles, but they can also be very large. On the passage of large numbers of bubbles, large amounts of bubbles, to the point that it can almost look like an ASD on the transthoracic.
The RV, I think.
The RV in that one, I don't believe it was. I don't believe so.
Even if it's dilated, it could be from the secondary cause, like not from the vehicle itself.
Yeah, it won't load again, I'm afraid. So Primum ASDs are the second most common type of ASD, seen in about 15 to 20% of all ASDs. And they exist along the spectrum of diseases known as AV canal defects, or atrioventricular canal defects, which involve deficiencies in the development of the endocardial cushions, which I'll explain a bit more about later on. And this is the most common cardiac lesion associated with Down syndrome, or trisomy 21. So Primum ASDs are they're a hole that forms just caudally above the intraventricular septum, just above the endocardial cushions, which is where the AV junction forms, and is caused by insufficient fusion of the septum primum, that first septum to come down, to the endocardial cushions. And compared to Secundum ASDs, it has a normal fossa ovalis, and oftentimes there's also issues with the endocardial cushions, leading to development of ventricular septal defect and other associated features of AV canal defects. So on the left, we have a TTE, interstitial long axis, showing an extremely dilated right ventricle. And also note that you can actually see the tricuspid valve in the right ventricle quite well. And it looks like it's around the same level as the mitral valve. And it's fairly unusual in a standard echo to be able to see the tricuspid valve in the right ventricle so well from this view. And then in the peristernal short axis view in the next picture, again, note the extremely dilated right ventricle and the flattened septum. And you can see that both the left and right atrioventricular valves can be seen here in the same plane. And when people have these AV canal defects, we call them the left and right atrioventricular valves rather than tricuspid and mitral valve. Forgive me if I accidentally say tricuspid or mitral valve. And then it's a bit hard to appreciate on this picture, but in the left atrioventricular valve, it also has the appearance of a cleft anterior mitral valve leaflet, although it is not technically a cleft, but rather it's a divided common AV valve, which has this appearance. And so this is the same defect seen in apical four chamber, a little bit off axis. So it can be seen quite well with anterior angulation during the apical four chamber view. And you can see that there's this defect just before the crux of the heart. And again, note that the usual offset that you get in the atrioventricular valves, where the tricuspid valve is more apically displaced and the mitral valve is not present, and the left and right AV valves exist on the same plane. So this is a subcostal view for the same patient. So primum defect is seen quite well in subcostal views because the defect is, again, perpendicular to the and you can also see that there's marked shunting from the left atrium to the right ventricle, as seen with this red color Doppler flow. So primum ASDs are, again, part of this AV canal defect spectrum. And you can have partial, complete AV canal defects. Partial AV canal defects, which are shown on the right in systole and diastole. They have a ASD, but they do not have a VSD associated with it. And they also have this finding of the AV valves being on the same plane. And they often, or they always have the left AV valve with an appearance of sort of a cleft mitral valve, although again, not truly a cleft. And then complete AV canal defects have a primum ASD, a common AV valve, as well as an inlet VSD. And so here you can see the complete AV canal defect in systole and in diastole. And you can see that in diastole, you have the two atria, the two ventricles, and this big hole in between. So you can imagine that there's a lot of mixing of blood as the blood moves between the atria and the ventricles. And it could move into both the right and left ventricle, but it could also preferentially go towards the right or the left ventricle, which is what we describe as either a balanced or an unbalanced anatomy. Sinus venosus ASDs are rare. They're about 2 to 10% of all the ASDs, and they can be related to either the superior or the inferior vena cava, although superior vena cava involvement is much more common. So sinus venosus ASDs are a consequence of improper positioning of the insertion point of the inferior or the superior vena cava, and they can be, again, located either inferiorly or superiorly, and these also have a normal fossa ovalis. So these are some still images. It's often very difficult to see sinus venosus ASDs on TTE, but sometimes you can see it from subcostal views. And oftentimes you need a TEE in a patient who has clinical suspicion of having a sinus venosus ASD because of right chamber enlargement and because of perhaps the positive bubble study. So in the first image, you can see that the SVC enters into the right atrium, but it's also in very close proximity to the left atrium, leaving this hole in between the right and left atrium. And then the second image shows similar anatomy, but it also kind of demonstrates the position of the IVC relative to the SVC. So this would be an example of superior vena cava sinus venosus ASD, allowing shunting between the left and the right atrium. And then in the third picture, you see color flow, and you see a large shunt moving from the left side of the heart to the right side of the heart through that defect. And so sinus venosus ASDs are often associated with partial anomalous pulmonary venous connections, usually of the right upper, right middle pulmonary veins, especially for superior defects. Inferior defects are usually not associated with partial anomalous pulmonary venous connections, but sometimes they can also have connections to the right pulmonary veins. Okay, so this is an interesting case that was seen in the same IX lab quite some time ago. This was a woman with unknown congenital disease that was diagnosed in China. She came to Canada, and she had her first echo done here to assess her cardiac structure. A transesophageal echo was actually the first test that was done, but I rearranged the pictures a little bit. So any volunteers just kind of want to say what we're seeing in the first picture? This is a transthoracic echo, subcostal view of the interatrial septum. What were you saying?
It looks like there's like
Yeah. So there's certainly some color flow across the septum, moving from right to left. So going away from the probe in this blue color. Agreed. And so in the second picture, bubble study. So we see bubbles in the right. We don't really see anything come over on the left, despite seeing this color flow on the left image.
Where's the IV site?
Sorry?
Where's the IV site?
Good question. This is the right arm. So any guesses at this point, what kind of polar are we dealing with on the basis of this color flow but negative bubble study? PFO, primum, secundum, sinus venosus, coronary sinus defect. Holy cow, I don't know.
I'll go with number 5.
Number 5, okay.
They have to put an IV in the foot in order to increase the pressure. Change the pressure.
It's a Bode special.
So what are you guessing? You know, what kind of... Okay.
I just remember the backstory.
So we got a mix of answers. So the next pictures are from the transep. That was actually the first test that was done. So I'll just kind of walk through these pictures. So the first image shows the left atrium on top, and then we see the IVC.
Look here,
Sorry.
explain why you're looking. There is a difference between the mouse and the position.
Oh, sorry.
Yes.
I'm just trying to find. Okay, here we go. So here we have the left atrium, and we have the IVC entering into the right atrium. Also note that there's this prominent eustachian valve, and at least in this view, we don't yet see any ASD. And then in the second picture, which is angulated slightly differently, we can actually see that. So I'm just trying to see if my mouse will show. We can see that the IVC also has a connection with the left atrium up here. And again, note this prominent eustachian valve. And then in these pictures, so we see colored Doppler put on, and we can see that there's actually this common connection between the IVC, the left atrium, and the right atrium with this prominent eustachian valve, kind of preferentially directing flow upwards into the left atrium. And then a bubble study, which is again done through either the left or right arm, I don't recall. But you see, similar to what we saw in the transthoracic echo, the bubbles only enter into the right atrium, but they do not pass over into the left atrium despite this defect. So here we have 3 different bubble studies that were done on the same patients. This first picture is actually the picture that I was showing before, which was done, through the left arm. And so that one is negative. Sorry, I'm just going to wait for this to load. It might take a second. And then on the left foot injection, the bubbles aren't as prominently seen as the other pictures, but if you can squint, so there you can start to see some bubbles coming into the left and right chambers.
Where's the right?
I think it would work with either foot. So yeah, here you can see bubbles entering into the left and right chambers nearly simultaneously, or in very close proximity to one another, or very close time to one another. And so this is consistent with inferior sinus venosus defect, which only allows the passage of the bubbles from the lower extremities. Partially also because of that prominent eustachian valve that sort of redirects flow and doesn't allow the bubbles to come from the upper extremities. Sinus venosus defect also would have accepted holy cow as an answer. So coronary sinus defects are very uncommon. They're less than 1% of all ASDs, although they're not technically an ASD. It's also known as an unroofed coronary sinus, but their clinical presentation can be fairly similar to ASDs. So this is one schematic of what coronary sinus defects look like. They're often associated with a left-sided SVC, and as it passes under the left atrium, you can get either a single hole or you can get multiple fenestrations in the roof of the coronary sinus, which can allow two-way communication between the left atrium and the coronary sinus. And then it's also often associated with ASDs and PFOs. Okay, so one more case. Any volunteers just want to say what the most prominent finding is on these images? This is an apical three-chamber transthoracic echo with color Doppler on the right side, and one main.
It's not a trick, right?
Sorry,
Not a trick view.
not a trick for you. You're saying, Pega? Yeah. So the coronary sinus here is extremely dilated, and you can kind of better appreciate it on the color because you don't see the color moving from the left atrium to the left ventricle, but you don't see it passing through the coronary sinus. And so this is the bubble study done through the left arm in parasternal long axis. And anybody want to say what the finding is here that says what this is, what that diagnosis is? If no takers, I will explain it.
So sailing to the left arm will classify the coronary sinus first.
Yeah, exactly. So after injection, you see opacification of the coronary sinus before the right chambers, which you can also see on this four-chamber view, and you can see this very dilated coronary sinus, obviously not the typical appearance on a four-chamber view. And so if you inject through the left arm, you get bubbles into the coronary sinus before it brings into the right atrium, like you said. And then in the next picture, we have a very nice M mode that was taken on the parasternal long axis. So you can see in this bottom row, this represents coronary sinus, and you can see opacification of the coronary sinus. Sorry, and most
There is difference.
yeah. So you can see the coronary sinus opacifies prior to the right atrium. There's one more part to this story. So here they actually injected the right arm, and interestingly, you see the same filling pattern. Again, you see opacification of the coronary sinus before the right chambers, which is not the typical thing that you would expect if they just have a persistent left-sided SVC. And so this is probably because of a bridging vein between the left and right SVC. And in this case, they probably also have an absent right-sided SVC, which is what allows the passage of bubbles from the right upper extremity, to go over to the coronary sinus before it goes into the right-sided chambers. So this patient did not have a coronary sinus defect, but I put this picture up just because a persistent left-sided vena cava is a common finding in people with coronary sinus defects. And when people have both a persistent left-sided vena cava plus a coronary sinus defect, it can cause bidirectional shunting, where you get a left to right shunt from the coronary sinus interatrial communication, but you also get a right to left shunt from the persistent left vena cava, which has deoxygenated blood draining into the left atrium. These people doing physical exertion will increase their pulmonary pressures, increase their right-sided pressures, and as a consequence, they could get cyanotic because of preferential shunting from right to left. Okay, so moving on to VSDs. So VSDs are the most common form of congenital heart disease after bicuspid aortic valves and PFOs. They're a diverse category of diseases, and the size and the volume of shunting will determine their clinical consequences. VSDs can range from benign incidental findings that we discover late in adulthood to palliative diagnoses that are incompatible with life. The nomenclature around VSDs can also be very confusing, so I'll try to simplify that a little bit. So VSDs come in four main types. You can have outlet, inlet, membranous, and muscular defects, as well as Gerbode defects. Outlet defects have many different names. They are sometimes called infundibular, subarterial, supracrystal, subpulmonary, conal, doubly committed VSDs, They probably have some other names too. Inlet VSDs are sometimes called AV canal type defects, and they're the other part of that story of AV canal defects that I was talking about before. Membranous defects can also be called conoventricular defects, muscular or muscular, Gerbode or Gerbode. And so here we see the location of each of these types of VSDs. If you look at if you were to remove the free wall of the right ventricle. So first you get outlets or infundibular subarterial supracrystal VSDs close to the aortic and pulmonary valves. From a deficiency of the crista supraventricularis, which is this ridge here, you can get inlet or AV canal defects located more inferiorly near the opening of the tricuspid valve and the mitral valve. Membranous defects are the ones that we see most commonly. They're caused by a deficient membranous septum, which is close to the aortic valve, and if it extends into the muscular septum, the defect is called a perimembranous defect. Muscular defects are surrounded by muscle within the trabeculated septum, and Gerbode defects are not shown here, and they're the least common type of VSD. They're caused by a deficient membranous septum between the left ventricle and the right atrium. So this picture nicely shows the different parts of the ventricular septal anatomy. So there's four major divisions. There's the inlet septum, which is near the orifice of the atrioventricular valves and inferiorly located. There's the outlet septum in green, which is near the aorta and the pulmonary artery, and it's superiorly located above a ridge called the crista supraventricularis, which I showed before. And this crista supraventricularis also separates the outlet septum from the trabecular septum, which is the thick muscular component. That's the major part of the septum. And then there's the membranous septum, which is a thin fibrous section that separates the aortic vestibule from the right, from the lower part of the right atrium and the upper part of the right ventricle. And then it's helpful to imagine how these VSDs are positioned on the short axis view around the level of the aortic valve. So Gerbode defects drain from the LVOT into the right atrium, membranous into the proximal portion of the right ventricle near the tricuspid valve, and outlet into the more distal portion of the right ventricle near the pulmonary arteries. And I'll show you some more pictures of this view later on. VSDs can be classified by their size. So small or restrictive VSDs are less than half the size of the aortic root, and they have an LV to RV gradient of over 64 millimeters of mercury. Moderately restrictive defects are about half the size of the aortic root, and they have a gradient of 36 to 64 millimeters of mercury. And non-restrictive VSDs are more than half the size of the aortic root, and they have a gradient of less than 36 millimeters of mercury. Smaller VSDs tend to be associated with loud stolic murmurs because of the high gradient, high flow, or high pressure, and they may be asymptomatic. Moderate ASDs cause left heart enlargement left and right sided enlargement from increased flow, and large VSDs lead to equalization of the left and right heart pressures, and if unrepaired, can lead to pulmonary hypertension and Eisenmeinger's. And sorry, I misspoke. Smaller VSDs have the loud murmur because of high pressure, not high flow. So muscular VSDs are relatively common in children, but very infrequently seen in adults. They're located deeper within the ventricular septum, away from the valves and in the trabeculated muscular portion of the septum. And they're surrounded by a complete rim of trabeculated muscle. They often spontaneously close during childhood, so we don't see them very often in adults. They're often small, and there can be multiple muscular VSDs in the same patient. And they can be small, but they can also be quite large. So this is a transthoracic echo, apical four-chamber showing this high velocity color flow in the muscular septum, consistent with the muscular VSD. And again, they can be quite variable in size. This one sort of has the high flow appearance of a restrictive type of VSD. And you can often, again, have multiple muscular VSDs in the same patient. This one, it looks like there's just one VSD. VSDs are generally not associated with any valvular abnormalities because of their more apical location positioned away from the valves. Inlet VSDs are relatively uncommon to see in isolation, and they're sort of the other components to that AV canal defect spectrum of disease, along with Primum ASDs. So when you have this heart tube, the endocardial cushions are these portions on the sides, which involute and ultimately develop the valves in the septum for the heart. When you have an endocardial cushion defect, you get a problem with this division of the heart, and you develop a common AV valve without a dividing septum, and you fail to differentiate your valves into your mitral and tricuspid valve, which is why in people with AV canal defects, we just call them a left and right atrioventricular valve. So on the left, we have a still image of an inlet VSD showing the VSD originating kind of just below the crux of the heart. And again, note that as with the other defects we saw, the left and right atrioventricular valves are on the same plane. And then on the video on the right, so this is an example of an inlet VSD, which is, you can confuse it with some other types of VSDs, but probably the main feature that lets you know this is likely an inlet VSD is the fact that, again, you can see the tricuspid or the left and right atrioventricular valves sort of head on in the same plane, which is an unusual finding in the absence of an AV canal defect. And again, you see the other associated features of right ventricular enlargement and pressure overload. So it's rare to have isolated inlet VSDs, as I mentioned, and they're generally associated with those other features of AV canal defects. They are often associated with Primum ASD. You usually have the absence of this offset of your left and right atrioventricular valves. Sometimes you get a single atrioventricular valve if you have a complete AV canal defect, and it's generally associated with this left-sided cleft atrioventricular valve, although again, it's not technically a cleft. Membranous VSDs are the most common type of VSDs that are found in adults, representing about 80% of the VSDs that we see in adults. They're located at the base of the septum between the atrioventricular and the tricuspid valves. So here we see a membranous VSD in peristernal long axis, zoomed in view of the LVOT. So it can be quite well seen on transthoracic echo. And here you can see that there's this perimembranous defect with high velocity color flow on Doppler. So this is probably the VSD that we're most familiar with seeing. And then here on peristernal short axis, we can see the typical location of the perimembranous VSD around the sort of 10 to 12 o'clock location, located close to the aortic valve and also close to the tricuspid valve, but notably on the ventricular side of the tricuspid valve. And again, note that it looks like it's fairly high velocity flow. And then it can also be seen quite well in the apical 5 chamber. So again, demonstrating the perimembranous defect right around here with high velocity color flow. And then finally, CW continuous wave Doppler through the VSD, demonstrating high velocity flow well above the 64 millimeters of mercury cutoff, which suggests a small restrictive VSD. Membranous VSDs are sometimes associated with aortic insufficiency and tricuspid regurgitation because of their close proximity to these valves and the high velocity flow, which can cause this sort of sucking effect or venturi effect that pulls at the leaflet cusps and causes regurgitation. And then less commonly, you can also get development of a double chamber right ventricle, which occurs because of a long-standing high velocity, high pressure membranous VSD, which causes focal hypertrophy of right ventricular muscle bundles at the margin of the VSD. And because of the development of this ridge, you get a proximal portion of the right ventricle, which is high pressure, close to the RV inflow. And then after the stenotic portion, you get a lower pressure chamber within the right ventricle, closer to the pulmonic valve. Outlet VSDs, which have many other names, supracrystal and condylar VSDs, are the least common VSD in people of European descent, but they tend to be more common in people of Asian descent. They occur at the outlet septum, adjacent to the aortic and pulmonic valves, and because they tend to cause deficient muscular support of these valves, they are often associated with prolapse of the cusps of the aortic or pulmonic valves and significant regurgitation. The prolapsing of the right coronary cusp can also decrease the effective size of the VSD as it sort of fills part of that hole. But as a result of that, it can also cause worsening aortic insufficiency. So here we see an outlet VSD on transthoracic short axis. And so it appears sort of similar to the membranous VSD with high velocity flow, but the location is different, with it situated closer to the pulmonic valve, sort of past the 12 o'clock location. So outlet VSDs are often associated with aortic insufficiency due to the prolapse of the right coronary cusp. This occurs about 2.5 times more often than it would with a membranous VSD. Probably because you have greater deficiency of the outlet septum, and this just leads to less support around the aortic valve. And if you have prolapsing of the coronary cusp, you can also develop a sinus of Valsalva aneurysm, usually a right sinus of Valsalva aneurysm, and downstream this could lead to complications such as rupture into the right atrium or the right ventricle. So sinus of Valsalva aneurysms are a very important complication to screen for in people with outlet VSDs. And then finally, we have Gerbode defects, which are the rarest form of native VSD, but tend to occur more commonly as a complication of other diseases, such as infective endocarditis. And Gerbode defects lead to shunting from the LVOT into the right atrium, compared to membranous defects, which shunt into the right ventricle. And so my apologies if the images are a little bit dark here, but this is a transthoracic echo, personal short axis, with and without color. And there's a small defect around the sort of the 9 o'clock position. And you can see on the color images that in systole, when the tricuspid valve is closed, you get this flow in blue, kind of bouncing off the closed tricuspid valve and moving upside. Yep, and kind of moving inferiorly. And then in diastole, you still get color flow moving from left to right, but it sort of follows the path of the blood flow through the tricuspid valve in orange. And then again, CW Doppler showing the high velocity jet in keeping with the restricted defect. So Gerbode defects are commonly associated with the infective endocarditis, in particular aortic root abscess. It can be associated with right atrial enlargement and tricuspid regurgitation because of the volume overload on the right atrium and right ventricle because of the left to right shunting. And then here, just to kind of demonstrate the 3 defects, Gerbode, membranous, and outlet side to side, although it doesn't show as well in this choppy fashion. But Gerbode defects, again, you can see, position my mouse. So Gerbode defects, sort of in the 8 to 9 o'clock position, goes from the left into the right atrium. And then membranous defects, membranous defects, this one, sort of going in the 10 to 11 o'clock position into the proximal portion of the right ventricle. And then outlet defects over here, going into the more distal portion of the right ventricle, closer to the pulmonic valve after the 12 o'clock position. And so just to wrap up a few pearls. So right heart enlargement should make you think about a shunt. And then if you see right heart enlargement plus evidence of an atrial shunt, you should think ASD, not PFO. I didn't talk about this too much, but you should always screen for pulmonary hypertension in people with shunts because pulmonary hypertension plus a shunt is a bad thing and highly concerning. AV canal defects, such as Primum ASDs, Inlet VSDs tend to have similar abnormalities of your atrioventricular valves, which we talked about, such as this cleft appearance of the left atrioventricular valve and the common level of the 2 valves. And VSDs can cause regurgitation of native valves as well, which should be actively screened for. References and just the acknowledgements. Thank you to Yazid for all his assistance with this presentation and with finding videos, which was extremely helpful. Thank you to all the St. Mike sonographers who took pretty much all the pictures in this presentation. And thanks to the St. Mike's fellows and staff who have been amazing teachers and mentors. So thank you for your attention. Any questions?
Thank you so much, Shamir, for going through all these holes. As a voyage through the holes, various holes in different locations, and in all various sort of a demonstration of their manifestations. So any tidbits, maybe either from you or the sonographers in the room, like in terms of investigating these holes in the heart, because they don't always come with a menu to tell you where to look for them.
Yeah, I mean, from my perspective, I think the one of the main features that should just trigger alarms is this finding of right chamber enlargement without another cause, which should prompt at least a bubble study and further investigation. And then a careful physical examination will sometimes describe murmurs, and if you don't find another reason for it on your echo, then that should also potentially prompt investigation for a shunt that you haven't. That's a bit harder to find. Otherwise, in terms of actively finding them on echo, I don't know that I'm experienced enough at that aspect. So, any other tips from the sonographers in the room? Always do a bubble study.
The doctor is asking Congenital ASD. Even in it's hard to establish a dilated RV sometimes, right? This RV is hard to focus because you can make the RV small, medium, large, but although it's still visually assessed RV compared to the LV, but be careful with the LV study that it's small. So bubble study is always helpful, and we can always start doing the bubble study in the F below. It's good right away. The sinus just starting to develop and our like the coronary sinus type of ASD. And again, even with right to that bubble study, with the case that you showed, still doesn't rule out an ASD. So
you don't routinely do bubble studies through the foot?
No, because actually that was done at the end of the day, and we had the eye nurse too. I guess that was Selena's case that even the eye nurse doesn't want to put an IV to the foot because it might create a thrombus, right? So it was very, very challenging case for them. And also with the imaging the interatrial septum, we routinely do a right lateral view to see the interatrial septum from the primum to secundum wall. But again, it's worth trying it within an adult because that's hard to visualize. And a subcostal view, the images that you've shown, that's routinely done in peds, where we invert the image to look for the SPC and ITC. So you can also see and try to see the rim or around the ITC and SPC, for example. Look for the partial anomalous type of SPC.
Right. Much harder to see in adults. So, yeah.
Color, because the ASD or Atrial flow here lower, you really have to bring that color scale at least within 40 to 50 centimeters. Yeah,
that's helpful.
Yeah, having a high index of suspicion is very important. I think we do have a protocol established for that reason. That's why we put color on all the different parts that we do to look for small holes or high velocity flow that may not be apparent with a defect on the echo sometimes. So any abnormal flow, you have to follow it. I think knowing your physical exam can also be helpful. But not always helpful because it doesn't come with a physical exam unless it's in your own clinic or your own patients. I think we cannot say more than enough that what you have demonstrated about using the bubble study. Bubbles help us to trace the flow, and especially agitated saline contrast. The challenge of that is like we're very lucky at St. Mike's that we can do this quite easily. Almost all our sonographers are trained to be able to put in IVs and being able to give agitated saline contrast plus echo contrast. it's not the case in the community. So what happened is they don't always have the opportunity to do the agitated signaling contrast or study IV, things like that. But I think as we move along in the last 10 years, more and more community labs are giving definitive type or Sonneville type echo contrast, so that more and more labs are able to put in IV to diagnose these things. Otherwise, they get referred to us and look at these things, and T also can be helpful, as well as cardiac MRI to further delineate, the holes and the finding. And not to mention, we're very fortunate again to have access to our resident pediatric cardiologist, Dr. Rahan, who often give us advice even when they are in their adulthood, and also our colleagues across the streets at UHN with the adult congenital group as well. So those are all our resources here. We're very fortunate to have that. Any other questions, thoughts, or comments from anyone? Comments?
Yeah, it's a really nice case of the lift persistent severe vena cava. You always hear that when you find a congenital heart disease, you should look for another. This was really a great example that was not expected, like to find a connection also from the right to the left.
Yeah,
So I was surprised with the finding. Yeah, truly. I have a question for the audience. Which chamber is dilated usually with the VSD?
Left.
All right.
Yes.
VSD.
Left.
Who say the left? Who say the right? Who have no answer? Yeah. Why the left? Because it's going to the right. Why the left is dilated? Because the blood system will go all to the
That was right.
and come back to the left, so it will dilate the left during the diastole.
So yeah, it's an EVA.
Yeah. Unless you have Eisenmenger, but always tricky question.
Yeah, dilation is usually the one
ASD,
after the shunt.
right, VSD, the left.
So going back,
It's right, that is the left.
going back to the left foot injection, if you do the right foot injection, will it add more information?
The right foot should be the same.
Same.
Yeah, because they'll both drain into the IVC together.
Oh, okay. So only one foot is okay.
Unless he's too miserable, unlucky person.
Oh.
Yeah, unless there's something else going on. I don't know what that would be. Because I don't think you should have two inferior vena cava.
But with the ASD, it should be the RA enlargement, not just the RA. It should be the RP. It's not an isolated RA enlargement. So be careful with that, because we only use 4.1 to define RA enlargement. And be careful with that as well. I don't know what that will be. Right. So visual assessment of the
If you check the guidelines, there is like proximal RBOT, distal RBOT. Even the proximal is like from the parasternal long axis, parasternal short axis. There's in the systolic area, the systolic area. So a lot to count. Even the mid, not just the laser, even the mid and the long axis. There is a lot. I think there is 7 parameters to assess the size of the RB. We are using only one
because you're only using one, and be careful with that.
Yeah, and the problem with this one is not indexed. So for the surface area to male, female, these things.
And you can always make it as, again, it's just for rotation.
Yeah, we are under your mercy to show
Yes,
us
it's our mercy.
Yeah.
Thank you, Samir. It was really a good lecture.
Thank you. Appreciate it.